Thank you very much. Good morning, everyone. I apologize for not speaking in Estonian. It's a real failure on my part not to have learnt Estonian in time for this conference. And in fact, I realized that I've actually spoken at this conference before, almost a decade ago in Tartu in 2009. So it's a delight to be back. And what I want to do in the next little while is to talk about the role of public health. And just to say before I start talking, my background is very much in making economic arguments for investing in public health, for investing in prevention, investing in promotion, making arguments for primary care to work with public health, for public health to work with secondary care, for public health to work with other sectors. And the minister was talking about schools, for instance. So that's where I'm coming from. I'm going around all the time trying to make arguments for early intervention, for prevention, for better health promotion. And what I want to start by doing is saying a little bit about where I think we are now in Europe in terms of health in the 21st century, then go on and say a little bit about the role of public health in Europe, and then emphasize the importance of partnerships, collaboration, coordination between you working in public health and people working in other aspects of the healthcare system, and indeed beyond the healthcare system. And finally, because I do have an economics background, I want to talk about what I hope is a useful thing, which is a way of making economic arguments to strengthen your case for having more resources invested in public health. So I'll talk about something called return on investments. So Europe really, its health, there are enormous challenges that we face now as we enter this new century. And if you've got incredible eyesight, and you may not have, but this is a slide, and you may hear more about this, I guess, today, about health in Estonia. But I was just looking to see from this international data where Estonia is, and what are the challenges that are faced by the system here now. And the changes over time, there are many positive things. This shows the top 10 causes of premature death in Estonia. And one of the positive things is that many of these numbers are negative. They're falling. So there are fewer premature deaths. So that's good. But we still see that heart disease is the primary cause of premature death in Estonia, followed by cancers, and self-harm and suicidal behavior is another issue. That's still very important. And we see the rise of things such as Alzheimer's disease and dementia as being a cause of premature death as well. Why do I show this slide? Well, I want to emphasize the point that public health has a key role to play with all of these conditions, within healthcare systems and also outside. There's so much that can be done to intervene early to prevent and tackle cardiovascular disease and conditions such as diabetes. Of course, lung cancer, we can think about smoking, and lots has been said about tackling smoking. Self-harm, I mean, there's always been good research done here in Estonia on self-harm prevention and suicide prevention. But there's lots of actions that can be taken to try and reduce that, and public health has an important role to play. Even with conditions like dementia. There was a study in the UK recently, or a paper in the Lancet, showing that about 35% of all dementias potentially are avoidable through early intervention in life, better lifestyles, healthier diets, tackling things like loneliness as an issue. So big roles here for public health as well, even for conditions such as dementia, which sometimes don't obviously feel like an issue that can be tackled. And it's the same as well if you look at a different way of thinking about things in Estonia, which is the change in the major causes to not only premature death, but living with disability, so morbidity, illness, as well as death. And again, there are positives here in terms of reductions in conditions such as heart disease, in terms of its impact, alcohol disorders and lung cancers as well. But you do see the rise of cerebrovascular disease. I can never say that. But again, the point here, nearly all of these are essentially non-communicable diseases, or they're injuries. And public health has a role to play in all of these. I mean, public health has a vital role to play in tackling all of these issues, and it can't be done purely by those working in treatment alone, but treatment has an important role to play, and public health must be working alongside and liaison with treatment services. And yet, even though there are strong arguments for tackling poor health, and even though the main causes of premature death in Europe now, or the main contributors to disease are non-communicable diseases, diabetes, the cancers, the cardiovascular disease, the depressions and stresses as well, there hasn't been so much attention given to public health by healthcare funders. And this is the same all over the world, really. This slide here is work that the OECD did recently, looking at how much is spent on public health. Admittedly, this is just spending within the healthcare system, so there will be some spending outside it as well, in schools, for instance. That may not be picked up. But you can see here that, on average in Europe, or in the OECD in this case, systems tend to spend around about 3% of their total health expenditure on public health. Just 3%. It's not very much. How does Estonia fare? Well, it's slightly better than the OECD average, but it's still around 3% of total health care expenditure. But even the best performing countries in this regard, Canada, it's only around about 6% of health expenditure devoted to public health. I mean, I think there are many reasons for this. My personal view is that people don't put enough emphasis on public health because it's, particularly when money is tight, because it's not seen as being as important as treatment or investing in hospitals. But the two are connected, they're linked together, they're not separate. And by investing in better public health, you actually free up more opportunity to do better treatments within healthcare, within the secondary care system as well. So they are linked. But no country does this very well. And there's lots we can learn. And I think as well, that's why something I will say towards the end of my talk about the economic arguments are really important to try and make these links, to try and convince health insurance funds or governments to invest more in public health. You may think that the UK is quite a good country in public health, but still we only spend around about 5% of our total health budget on public health. So there's a lot to be learned everywhere on how to improve things and how to strengthen public health functions. So, and I could, but I didn't because of time. I could have shown lots and lots of slides showing positive things in terms of reductions or increases in life expectancy, reductions in all sorts of diseases. So there are positive things happening across Europe, definitely, and public health has made a major contribution to those. But I want to focus now on what I think and what the current thinking is, in a sense, on the role of public health, particularly in Europe. And this draws a little bit on work that I've been involved with and with the World Health Organization and indeed other kinds of strategies for public health. So what is public health actually about today? Well, I came here 10 years ago for the Tallinn Charter in 2008, which was all about trying to make the case that investing in health actually is about investing in the wealth of society as well. Better health is good for all. It leads to prosperity. Very positive. We had a wonderful meeting down at the theatre. One of the things that the Charter emphasised was that health systems are much more than healthcare. They include disease prevention, they're about health promotion, and they're also about trying to influence other sectors. Now, the challenge here, of course, this was in 2008, and this was just really before the economic crisis started. So the economic crisis started in 2009, more or less, at least in England, about 2009. And what you will see, and I won't show a slide on this, but you will see across many countries in Europe and outside Europe, spending on public health starts to fall as budgets get tighter, as money is tighter within systems. In fact, public health and indeed mental health actually was the other area where spending really fell, perhaps reflecting the perception that these were less important priorities when money was tight. But I've argued in the past that was a mistake, because it's actually at times of economic disturbance, of crisis, that it's important to invest in prevention, in promotion as well. So there was a positive charter in Tallinn, but things perhaps got, there was the disruptive effect of a major global economic crisis. So it was really nice to be able to come back to Tallinn over the last few days and see where we are now, and hear about this concept of including and investing and innovating in health. And the reason I mention this is because it was a really strong focus of that meeting, that WHO organised meeting with the Ministry of Health here in Estonia, very, very strong focus on prevention and the role of public health. They were, I didn't do that. It moved itself. Do you know, anyway, I know why. Anyway, I've got a slide that changes automatically. I'd forgotten about that. But the point here is that it's about reorientating the system to have more focus on primary care as well and public health, to strengthen coverage for more cost-effective and quality early intervention and preventative services, and also to improve cooperation with key stakeholders within the healthcare system and outside of the healthcare system. And these are just quotes taken from a document that was endorsed by the conference yesterday. So this is hot off the press, you could say. But the point here, I'm trying to say, public health is incredibly important to the future direction of healthcare in Europe. It's central, in fact. That's not to say that other aspects of the healthcare systems are less important, but it's recognising that public health has a vital role to play in innovating, in including everyone, and in investing. So what should the public health system be doing? And again, your eyesight will need to be good to see some of these things on the screen. But you know better than I do, it's about many different things that can be done. It's about addressing underlying determinants, risk factors for health. It's about dealing with behavioural risk factors as well. But it's also about early detection, early intervention in primary care, and it's about actions within the secondary care system to reduce the risks of complications of disease, or to reduce the risk of multi-morbidity that can lead to poorer health outcomes for people with existing health conditions. Actually, a good example of that I'll mention again in a minute is about diabetes and diabetes care. And really important to think, for instance, about the psychological impacts of living with chronic conditions, because if you have poor mental health with a chronic physical illness, there tend to be poorer outcomes and more cost as well. But I'll come back to that. So it's about actions within and outside of the healthcare system. It's about primary prevention, but it is also about secondary prevention. And I think crucially as well, it is about working with others, because not everything can be done by by doctors, but an awful lot can. But things that happen in schools or in workplaces need the involvement of the public health community. They need the advice, they need the support, they need the guidance for effective actions to happen. So you really have a very important and essential role in that area as well. So many, many different things that can be done. So actually, what is actually happening now in Europe in terms of public health, or where is it at the moment? Well, I think in terms of where Europe is going, you will see in different governmental strategies, public health strategies right across Europe, more emphasis on tackling risk factors to poor health. The obvious ones, in a sense, the risk factors for non-communicable disease, the issues around diet and activity, addictive behaviours, gambling and those kinds of addictions, the environment as well, air pollution and work environment, stress, all those kinds of things. And what I think is encouraging is that you will see more incentives to think more about prevention and promotion within primary care as well. In my country, in England, to be precise, rather than the UK, that's a long story, but in England, yeah, it really is a long story. Anyway, no, it's not, no, I'm not going to talk about politics. It's too depressing, it really is. But anyway, the point is, in England, we've had a system for a number of years where primary care doctors, GPs we call them, general practitioners, they get paid extra amounts of money for fulfilling public health functions. Now, whether that's screening for physical health problems, whether it's about giving advice on smoking and smoking cessation, whether it's about actually receiving additional money to liaise more with secondary care specialists, which is starting to happen as well. There are financial incentives built into our system to encourage more emphasis on prevention and promotion. Does it work? Well, there's some evidence to suggest it does. It does change the patterns of behaviour of primary care physicians. They are more likely to do preventative actions, although it's sometimes difficult to absolutely link that to changes in outcomes. But there's a really important role to be played by primary care. And actually, as was mentioned earlier, it's not just about doctors, of course. Well, it's not just about primary care family physicians. It's about the dentists of this world. It's about the ophthalmologists, the eye doctors, who all have a vital role to play in prevention, as well as in management of health problems. The other area that's really becoming quite big is facilitating intersectoral action, and I'll come back to that, but that's about working with schools or workplaces or in the environmental sector, working with sports to promote physical activity, etc. And in fact, I did some work recently for the Swedish government, for their health and social welfare departments. And of course, you'll see lots about taxes. Lots of sugar taxes have been introduced. So there are good measures there that can be taken at a governmental level as well. And you also see measures about alcohol pricing now starting to happen. It's been introduced in Scotland, a unit price for alcohol, and it probably will happen in Ireland as well soon. And then another thing you might see, and this is also a role for public health, I think, is about behavioural interventions. What little things can be done to try and influence the choices we make? And can you, for instance, how do public health practitioners, are there things you can do to make it easier for people to have a more physically active lifestyle? And that's about you possibly working with local governments or people who design new towns or roads, or to make sure people can walk places or to cycle or things like that, or make it easier to cycle to work by providing proper facilities there. So there's lots of things that can be done, and a lot of things are about working with primary care, but they're also about taxation, and they're also around behavioural interventions. I do want to mention, in terms of public health as well, there's a new document that's coming out of the WHO. In September it will be released, which is all about how health systems should respond to non-communicable disease. And again, I just want to emphasise how important public health is in that document. There's a real focus on public health transformation, And there's a real focus on things such as strengthening capacity of public health functions. There's a recognition that public health courses, public health degrees, there need to be new skills in those to strengthen the work, and also to strengthen the abilities of public health practitioners to communicate with others, to communicate with other sectors, to work in multi-sectoral teams, and also to think more about health inequalities as well as overall health outcomes. So workforce planning is incredibly important as well in terms of the role of the public health professionals within overall approaches to tackling non-communicable disease. And again, an English example of this, you will see in our general practice, our primary care doctors. In our system, they often are just doctors with maybe a nurse or two in the practice, but that's changing. More and more practices will have a public health specialist, or they'll have a physical activity person, or a person providing psychological therapies and supports. So they're becoming much more multi-practitioner practices with a strong emphasis on public health. The same could be said for our early intervention for mental health services, where an emphasis on physical health protection as part of the treatment for poor mental health is becoming more commonplace. And it's really important to coordinate better with primary and secondary care. I don't know if you're familiar with this particular image from the World Health Organization, but it sets out 10 core functions of public health organizations. And I'm not going to go through all of them now, but I do want to focus on disease prevention that's shown here in the slide, and health promotion, the service delivery aspects, and some of the thinking around that now. So again, just to emphasize, a real role for public health in terms of primary prevention, which I'm sure you're all absolutely familiar with, the vaccinations and so forth, and population well-being, promotion of population health. But key interventions, of course, in childhood, in terms of a range of screenings and vaccinations, and of course, for older people as well, influenza and the like. But there are also important things to be done in terms of secondary prevention for people who already have risk factors in place. So about good screening programs around blood pressure and diabetes, around cancer screening programs as well, around cholesterol management, those kinds of things. Really important areas to look at, which require collaboration with primary and secondary healthcare systems. And then there's the issue of tertiary prevention, really not forgetting that public health has a role to play in reducing the risk of multimorbidity, reducing the risk of complications in people living with chronic disease. And again, I'm repeating some things, but I'm trying to emphasize the point, and this is from this particular publication, that primary care plays a vital role in this. Primary care is seen as really important for the delivery of what's called universal healthcare coverage, universal health for all. But there's been too many healthcare systems where it's not been strong enough, the function. And again, there's an opportunity for public health to be much more embedded, I think, in all healthcare systems within the primary care function. And there are some interesting examples of that. I mean, much further to the east of here, in Kyrgyzstan, you'll see examples now of collaboration between public health and primary care teams, which has been quite effective in dealing with issues such as hypertension. But what about other things such as I want to mention collaborative care and diabetes. Diabetes is a really challenging problem right across Europe. And this is an old slide. It's 10 years old, but I think it's still quite powerful. And there's lots of new evidence supporting this particular approach. And that's about better management of depression in people with diabetes in primary care, and recognizing that there's an important argument for trying to prevent people developing diagnostic clinical levels of depression in terms of managing their diabetes. This is an American study, but it was a really effective study where you had nurses performing a public health function, reminding people, giving them advice and support about how to manage their diabetes, but also it was about providing psychological support in the community. And you can see here costs over 5 years for people who receive usual care. And you can compare that with costs for people who receive this collaborative care program, which involved the primary care doctors being more actively involved with public health professionals in their teams. And what you see here is consistently lower costs. Better outcomes, lower costs. And that's really important because diabetes, just one example, but complications of diabetes are incredibly expensive. And of course, they can have profound impacts on people's lives. In fact, there's work that suggests that complications of diabetes account for 75% of the cost of diabetes. So here we're talking about the heart disease, we're talking about the kidney failure, we're talking about foot ulcers and possibly amputations, glaucoma, the loss of eyesight. All these things really lead to higher costs. And that links me to saying as well that there's a role for public health to be much more active in raising awareness of what can be done within the secondary care system to try and reduce some of these risks. And I'll give one simple example from England, where the local public health agency were very influential in convincing the hospitals, this was in a couple of different locations in England, to invest more in specialist nurses whose role was to help people manage their diabetes, to look after their general health more, and to try therefore and avoid some of the complications. And what you will see consistently here in this study, in every single one of these hospitals where they invested in a public health, a preventative, focus in terms of diabetes care, the benefits far outweighed the costs because they were avoiding more complications. They were avoiding more amputations and chronic disease problems that are associated with diabetes. So that, I don't think, would have happened without strong arguments being made by public health professionals in the area that this was an important role to take on because it took money away from budgets to do this. But they were able to argue for this, and this program has been very successful. So there's lots that can be done within healthcare systems, but there are also things to be done outside of healthcare systems as well, and working in partnership, as I've said already, between primary care and secondary care, but also with schools and workplaces and others generally. So how can that be strengthened? I want to give some ideas which I hope are useful to help think about how to strengthen these links. Well, there's a lot of focus now on intersectoral actions. And indeed, the conference in Tallinn this week had a lot of emphasis on how do we make these intersectoral actions work better and how does public health achieve this? And it came out of the conference, but it comes out time and time again. Public health professionals are vital to really make these things happen, to get different sectors to work together, to give advice to different sectors on the value of investing in public health. And they can work across different sectoral boundaries. But there is a challenge for public health professionals, I think, as well. And the challenge is, can you talk about public health without always mentioning the benefits to health? Because sometimes if you want to convince the education sector to invest in health or employers to invest more in health, then maybe it's also important to make the arguments in the language of those sectors, the language of the school, in terms of better child performance in school, or less teacher stress, or less absenteeism from school by children, or less bullying in school. So making those arguments which are about health, but they're not health messages. So what I'm trying to say is that sometimes to make the health message in different sectors, at least in England, it's really helpful to emphasize the benefits to those other sectors in terms of what they think are their priorities. Okay? So trying to identify what's good to other sectors as well as what's good to health. And the same thing can be said about making the case for investment within healthcare systems as well. Because if you prevent mental health problems, and this means there are fewer physical health problems within healthcare systems, that's a win-win potentially for both sectors. And there is evidence that poor mental health, for instance, is associated with higher risks of poor physical health. So the point there is that making arguments in a slightly different way, thinking outside the box. And I know that's not easy to do, to go along to to schools perhaps and say, look, the reason for investing in resilience or physical activity in programs in schools is because it improves child concentration or child performance in the school, or it makes the school atmosphere better. They're not direct health messages, but they increase the chances that, at least in my system where schools have to pay for these services, not the health system, it increases the chances that the schools will actually do this. So there are things there to think about language. Can you think about a different language, or do you already do this perhaps, to think about the ways to work with others? And there's just some examples there. So the argument for primary care, investing in prevention actually reduces, well, you never reduce the workload on primary care perhaps, but you may free up more time in primary care to do other things, to be more effective still in dealing with health issues. For workplaces, about better workplaces. For schools, as I mentioned, it's about things that schools are interested in, that the education system is interested in. And you'll find papers around this. I mean, these are just random papers I found in the literature looking at how alcohol impacts on school performance. So if you're thinking about alcohol policies or about trying to get public health messages to young people about avoiding harmful drinking, or you're trying to get schools to provide those messages, then maybe it can be helpful to highlight the impacts of alcohol and academic achievements. And there's studies in America, there's studies in Australia, there's studies in other places doing that. That's just one example. There's another issue which I only want to talk about very briefly, which is about funding and responsibility and fragmented funding. Because one of the challenges we have in England, and I don't know in Estonia, but in England, one of the problems is that some of public health is delivered by local government, some is delivered by our health service, and there are also some functions delivered by the education system or by the transport system, and they all have different agendas, they have different budgets. People may not necessarily like each other or trust each other, so how can you actually build partnerships? And one way to do that is to think about ways to share funding, to share resources, for people to work in the same building and talk to each other. I know that sounds simple, but there is evidence that if people know each other, they're more likely to work well together. But actually creating joint funds and having joint priorities for public health actions can be an interesting thing to think about, and it's something we're starting to do a lot of in England, but not just in England. And just to give some examples of this, so in Finland, there have been for a number of years local health promotion funds which are conditional. The money's only given out if it's an intersectoral activity involving more than one sector. The same happens in Canada. We now, at the bottom here, we now have in England very powerful local government mayors in some places. Actually, in England, it's not the mayor of London who's the most powerful mayor, it's actually the mayor of Manchester or Birmingham, because the mayors of Manchester and Birmingham, they have control over the healthcare system, public health and education, and quite a lot of areas of responsibility. In London, that's not the case. But in Manchester, there's now work, because the mayor has control of these different functions, there is investment in actions to try and help people who are out of a job, give them interventions to improve their physical and mental health, because it's believed this will help people get back into work, because people become less confident, they lose the will to look for work in a sense. And so that's a strong focus of action now at local level in England. I've got 6 minutes and 36 seconds left. And I want to, so I've tried to say a bit about if you take nothing else from this, hopefully you see that public health is central to the challenges of 21st century health in Europe and indeed everywhere. The focus is on non-communicable chronic disease by and large, and cancer these days is a chronic disease, I would say, as much as anything else. So lots of problems, and it's about mental health, by the way, as part of those chronic disease challenges as well. Sometimes it's overlooked. But I've tried to say that there are arguments for doing things and working much more in primary care, and arguments for work for public health to be involved and to be part of teams and to give advice and support in secondary care systems as well. And there's a vital role in linking across sectors, because some of these things don't happen in health systems as well. Lots to happen in primary care and secondary care, but lots outside as well. And I want to end by just highlighting very briefly what we do, and it's not just we in the UK, it's happening in other countries as well, such as Sweden, for instance, producing what are called return on investment analyses to strengthen the case for taking action on public health. And I'm going to mention work. We have a national agency called Public Health England. They are responsible for allocating money on public health, for giving advice to local areas, all sorts of things. They're a national strategic body, part of the our National Health Service. And in the last 2 or 3 years, they've invested time and resource in return on investment tools. And what they do is they calculate how much it costs to deliver promotion and prevention services, and how much money is saved or as a result of better outcomes. But not only that, they think about who actually pays and who benefits, because sometimes it may be the primary healthcare system who pays, but it may be another sector that benefits. So children's health improves, the education sector maybe benefits as well. So it tries to look at some of these issues, and these are the areas they've looked at so far: colorectal cancer, diabetes, end-of-life care, weight management, oral health for children, so dental health in schools, mental health promotion, musculoskeletal diseases, employment, falls prevention, an incredibly expensive thing, at least in the English healthcare system, falls, hip fractures and the like, and helping kids get the best start in life. And just a couple of examples down here. They have complicated tools, and they're all available to look at online. You can look at them here in Estonia as well. They're available. So the tool for falls prevention estimates that for every dollar you invest, over time, over $3 are saved, it could be euros, it doesn't matter, to the healthcare, to the economy as a whole. And that's really a saving to the healthcare system, but also in our country, in England, to the social welfare system that has to deal with problems if people can't live independently because they've had a fall, for instance. And you can think creatively as well. We looked at work around debt advice. In the English system, lots of people get into debt, credit card debt and the like, or serious debt, and it has an impact on their mental health. And primary care doctors now provide space in primary care practices where debt advice services are provided. The idea being that actually dealing with financial problems will improve people's health. Okay? And we'd like to think, modestly, that some of the work that we did showing there was a positive return on investments helped these programs to keep going, to be sustained and funded. And I think we had a tiny bit of influence on that. So if you're interested in more on this, there's lots of these tools out there. The one that we particularly worked on was about mental health promotion, and we have 8 different interventions that we looked at. And very quickly, just to show you one, to give you an idea of what we did, we looked at an intervention to tackle loneliness, because loneliness is associated with poor mental health, and indeed cardiovascular disease, strokes, and dementia as well. And the intervention was trying to, for doctors, for primary care doctors, to refer people to group activities, to choirs, or to just joining a cinema club, or going for a walk or a reading group. It was about group activities, different group activities. And we identified the costs of the interventions, and then we tried to identify how many costs would be avoided over different years. So reducing costs to seeing a primary care doctor, reducing the need for depression treatments, for self-harm treatments, reducing the need for cardiovascular disease treatments or strokes and dementia. You get the idea. The idea is to show that there are different impacts over time that can be linked to dealing with a risk factor for poor physical and mental health, in this case loneliness. So that's one example of the kind of thing that we do. And different local government areas who have responsibility for public health, they're able to use this tool with putting their own local data and see the potential return on investment. So I know that's rather complicated and a lot to take in, but if you can show people that public health is worth doing, not just from a moral point of view, because of course it's morally essential to improve the health of everyone. No one should be left behind. But if you can also show there are economic arguments for doing things, then maybe some of those people who aren't so interested will get interested as well. So I'm not saying the money arguments are the most important, but they can be a useful additional tool to think about. And there are examples of this going on, as I said, in Sweden as well, if you're interested in things closer to Estonia. So I've got 30 seconds left, so I've timed it about right. So really to summarise, public health, it really does need to be at the core of what we do today in health. And it's about working with specialist care and primary care and working across sectors. So you're going to have to be very busy people and multitask. And I know that's challenging. And you need support to do that. And I would argue as well, it's about being innovative. And one thing I haven't mentioned here in Estonia, of course, you have all this wonderful investments in digital technology, use of online interventions, and there are great potential ways of innovating in public health using digital technologies as well. And there's a great opportunity for you to think about that if you don't already think about it, and you probably do. So those kinds of innovations as well, and thinking about economic arguments where they can help you convince different policymakers or doctors or people working in schools or wherever that health is as important, but public health is as important to them, that health promotion is as important, even if it's not necessarily their primary focus. So I really hope that's helpful. My time is up, so thank you very much.